Hey everyone, Sarah Krager here, talking about today the critically ill cirrhotic patient. So I kind of have a love-hate relationship taking care of these patients because they are so sick and they're just completely falling apart. They look like death. And when I first started taking care of them, it was more on the hate side of the relationship where I was just like, what am I even doing? Am I going to get this patient, forget out of the hospital? Can I get them out of the doors of the ED? But over time, I've actually come to really like taking care of these patients because even though they're so sick, they're so complicated, sometimes they're rescuable. And if you do your job right, if you sort of take this very complicated disease entity and you manage it well and thoughtfully, sometimes, in fact, often, you can get them through. Now, in some patients, what that means is getting them through transplant. But even in patients where they're not transplant eligible, or they're being worked up for transplant, or that's just not where this is heading, even in those patients, often you can substantially turn them around. But when they come in, they look awful. They look so sick. These patients, they look much sicker than your heart failure patient or, your lung transplant patient. They look so much sicker. Why? It's because it's an all systems down scenario. And that's the thing with the cirrhotic patients, is that, if you have a heart failure patient, the heart's the problem. If you have a, patient with ILD, the lungs are the problem. If you have a cirrhotic patient, your everything is your problem because very rapidly the sequelae of cirrhosis affect every organ system in the body. And so that is why we are going to take this basically as a systems-based thing. So we are going to cover 6 different areas and 6 different complications you're going to see in patients with chronic liver disease in the emergency department. They're going to prevent critically ill with one or often more of the following: encephalopathy, hemorrhage, infection, renal failure, plus minus some kind of pulmonary complications, and they also have some metabolic problems. Now, here is the thing about taking care of the acutely ill cirrhotic patient. It's a masquerade. It's often very difficult to figure out what's going on with them because so many of their organ systems are down at the same time that, they can come in for what you think is a neurologic problem and it turns out they're having a GI bleed. And because whenever you have a situation like in these patients where so many things are going wrong on so many different levels at the same time, it becomes rapidly very difficult to figure out what's my primary problem and what my secondary problem is. Not only that, but it often is the case with these patients that whatever the primary problem that caused them to come in has now caused a secondary problem, but that secondary problem is now the biggest problem. And so these patients sometimes have more than one thing going on. They almost always, when they're this sick, have more than one process going on. They almost always have more than one organ system down. And it can be very difficult to figure out which came first and what's happening. And the key thing is not to miss the fact that just because it looks like one thing, it could be another. Maybe the first thing caused the second thing, or maybe now the second thing has taken on a life of its own. Now, I have found it helpful to think about the pathophysiology of the disease that's happening to them because it helps me understand why. Why is it that all of a sudden everything goes wrong? Everything goes wrong. And it's actually quite interesting, but also for me helped create this sort of integrated perspective on how these patients get so sick and why. And the key processes underlying the majority of the pathophysiology of complications of chronic liver disease are 2 things. 1, portal hypertension, and 2, systemic vasoplasia. And it's more complicated than that always. Of course, nothing's that simple, but for me, the thing that I found most helpful clinically, these are the things that explain and sort of allow me to clinically reason through a lot of the pathophysiology to help me think about their care. We're going to go through each of these one by one and talk about their pathophysiology, what they look like, how to assess them, and how to treat them. It's going to be a little drinking from the fire hose because, this lecture should probably be 10 hours and I'm going to try and keep it a lot shorter than that because each one of these topics is a lecture in and of itself. But we're going to try and hit the key points. If you don't remember anything else, do these 2 things and then read more about the ones that you're interested in. So let's start with encephalopathy. So the pathophysiology of a hepatic encephalopathy in these chronic liver guys, it's mostly arising from sequelae of the portal hypertension. So what's happening here is that your portal hypertension, you get all these collaterals, right? Because the pressure in the portal venous system is so high that basically eventually that pressure sort of gets into these collaterals. It opens up. And the problem with them is that they're portosystemic collaterals, meaning the following. If you have collaterals that go around the liver rather than through the liver, and that's what happens due to all this portal hypertension, the blood doesn't go through the liver. There's a reason the blood goes through the liver. There's a reason bodies are designed that way. It's because the liver does nice things for you like clearing ammonia. So that is one of the many complicated but probably core pathophysiology. Now, I just told you that in some way, hepatic encephalopathy has a lot to do with pneumonia. I'm now going to try and convince you that take that piece of knowledge, you're aware of it, now forget it, and that's the last time I want you to think about ammonia with hepatic encephalopathy. Yes, I mean it. Why? Because hepatic encephalopathy is a clinical diagnosis. I want this up there on Broadway with lights, like look at me, look at this one. If you only remember one thing, clinical diagnosis. Okay, I'm going to say that more than once during this talk if you only remember one thing, but this is an important one. It is a clinical diagnosis. But you say, what about ammonia? I've been taught to always get that. When I'm on my medicine rotation and somebody's altered and I forget to get an ammonia, I get in trouble. So what's the deal with ammonia? So ammonia in hepatic encephalopathy is sadly one of the great myths in modern medicine. I am actually going to read you a quote from a recent paper summarizing this issue. And I'm just going to read you the whole thing because this is actually an important one. Ahem. Many physicians utilize serum ammonia to diagnose, assess severity, and determine the resolution of hepatic encephalopathy in patients with chronic liver disease, despite research showing that ammonia levels are unhelpful in all of these clinical circumstances. So tell us what you really think. Hepatic encephalopathy in patients with chronic liver disease is a clinical diagnosis of exclusion that should not be based on ammonia levels. And that's why I'm including this quote. They clearly have fairly strong feelings about this. And yeah, but it's so hard to get people away from that because, what we like, numbers. There's a cutoff, there's a number, fantastic. What we don't like, complicated clinical assessments. Unfortunately, that's just what you're dealing with liver patients and encephalopathy. And it's just important because I think often we go in both ways. That we say, oh, the ammonia is not that elevated, therefore they don't have hepatic encephalopathy. Or we say, oh, yeah, it's elevated, that's why they're altered, they must have it. So I if somebody gets it, I actually do what these people in this paper actually suggest doing, which is either don't get it in the first place, or if you do get it, ignore it because you don't know what it means, and just go along with your clinical day and assess them clinically. Now, if you have a patient that you think has hepatic encephalopathy, which can sort of run this very, very large gamut from anything from being like, insomnia is often an early thing, personality changes, to, sleepy, confused, all the way to completely obtunded. Okay, I'm thinking about it, it's in my brain, maybe that's what they have. But the question you then need to ask yourself is one of these chicken egg things. Is hepatic encephalopathy the primary cause of the altered mental status or not? Now, sometimes you don't know, but let's say you're like, I think there's a good chance that actually it is. So you're working through that first question, and then that begets a second question, which is, if so, what precipitated the hepatic encephalopathy? So I'm saying, okay, my patient's altered. I don't think they have a meningitis. I don't think they have a head bleed. I think this hepatic encephalopathy is what's causing the altered mental status, but what precipitated it? Because sometimes the patient just, didn't take their meds maybe. But hepatic encephalopathy in these liver patients is often a sort of, I don't know what to call it, canary in the coal mine thing. It often is a marker of other badness happening. So all kinds of things can precipitate it. GI bleeds happens all the time. You get all that blood in your gut, then the protein gets broken down, and the next thing you know, hepatic encephalopathy. Sepsis will do it. Hypokalemia, this is a very common one. Alcohol or benzo use, and dehydration. And especially when dehydration and hypokalemia go together, it is very frequent that patients will develop hepatic encephalopathy. And so you need to be thinking about, is it just they stopped taking their lactulose, or did one of these things precipitate it? Now, of course, if it's just dehydration and they need a little potassium, that's easy. If it's a GI bleed thing, that can get more complicated. If it's sepsis, where's the sepsis coming from? But that is the proper chain of reasoning. Now, management, well, I like to think about management in 3 categories. 1, I'm going to work on identifying and correcting any of those precipitating causes. 2, I'm going to try and address the hyperammonemia, recognizing that my ability to accurately measure the effect of ammonia on the brain is not really reflected in a blood ammonia test. And so I'm going to address the hyperammonemia, but I'm not going to use the sort of blood ammonia test as the metric by which I decide if I'm doing it well, to be clear. Then the third one that often becomes an issue in these patients is airway. So precipitating causes. Often it's a bleeding issue. Are they having a GI bleed? Is it an occult GI bleed? Do I need to control the bleeding? They're also often dehydrated, either with or without a GI bleed. So do I need to give them some volume resuscitation? Electrolytes. So hypokalemia can do this, and so aggressive electrolyte repletion. And if that's the problem, then often they're also hypomagnesiemic, so I check and replete both, because you're going to have a hard time getting the potassium repleted if you forget about the magnesium. And then sepsis. These guys often get encephalopathic from sepsis. Sepsis both can just generally make people encephalopathic, but also can act as a trigger for hepatic encephalopathy in these patients. And so I'll sort of go sepsis hunting because it can be very secretive in these patients if I'm looking for a cause of my hepatic encephalopathy. Now, hyperammonemia, what I'm going to do about it? Well, lactulose. So, in the ED, you're going to give them 1 or 2 doses, great. You usually titrate them to bowel movement, you're going to start some lactulose, you're going to give some rifaximin. Everybody knows that, that's the easy part. The hard part is when the nurse comes to you and is like, you ordered all this lactulose, but the patient's way too altered to take PO, so what do you want me to do? That is when this gets a little bit tricky, because you now need to make a decision about the airway. And this often becomes the big sort of sticking point, tipping point, decision point in the management of hepatic encephalopathy. Because correcting precipitating causes and writing for lactulose and rifaximin, that's kind of easy, in a way. But do we intubate them? What do we do here with their airway? So, I think the first question is, are they protecting their airway? Because if they're not, okay, that's easy, then just intubate them. If they are protecting their airway, then it gets harder. Because if they're protecting their airway, but they're maybe not quite enough to take PO medications, then what do? What I will often do is put an NG tube in these patients. Why? Because if you don't, you end up in this situation where you're saying, I think they have hepatic encephalopathy, they're altered. Because they're altered, they can't take PO. The way to fix their hepatic encephalopathy is to give them PO meds. Oh wait, they're altered, they can't take them, so it gets worse, so they get more altered, and you just end up in this vicious cycle. You got to break the vicious cycle. So what I usually do is I just put down an NG tube, okay? Because this does 2 things for me. 1, if I try and put down the NG tube and they wake up enough that they're with it and coordinated enough that they're trying to punch me in the face, then maybe I can actually have them take PO, right? Use that moment to be like, okay, I won't do that to you again if you just take some PO right now. Because sometimes you just weren't trying to wake them up quite aggressively enough, and shoving something down their nose will do that often. So sometimes they wake up and you can get them to take PO, now you know. But sometimes it's fine. You just put down the NG tube and then you give them the lactulose and the rifaximin and whatever else you need to by the NG tube. What you don't want to do is wait and dither and try rectal lactulose, because it just, especially in the ED, so just make a commitment. If they're protecting their airway and you can't take PO, try putting in an NG tube. If it works, fantastic. If it doesn't work, then you may actually need to intubate them so that you can appropriately treat them. Be thoughtful about it, but again, the way to do it is not to just let them sit there. Now, next thing you need to do is, if, let's say, you've intubated them, now you put them on the vent, you actually want to avoid alkalosis in these patients. Interesting thing about alkalosis with patients with hepatic encephalopathy is that what it can actually do is cause increased transit, increased crossing of the blood-brain barrier of ammonia. And that's not exactly what you want. That's actually the opposite of what you want. So it's tempting to be like, yeah, let's make the CO2 look really pretty, but no, actually, if anything, you want to let these patients be a little more on the acidemic side than the alkalemic side. Now, what about sedation, right? Because you've now intubated this patient. Benzos is probably not an ideal situation. So I usually use propofol for these patients. It's fast on, fast off. Clearance is better. It's not going to stick around like benzos and Versed in these patients, stick around forever. Propofol is my personal sedation of choice. Precedex is another great choice. But if you can avoid benzos, unless the patient's in fluoride alcohol withdrawal, it's probably a good idea. Okay, moving right along, hemorrhage. So these patients bleed all the time. This is probably the most common and frequent complication you guys have seen of this. So what is the pathophysiology of GI bleeding complicating chronic liver disease? Well, it's the portal hypertension again. This one is easier and more straightforward to understand, right? You got portal hypertension, so your esophageal and gastric varices just get all distended, right? Remember those like portosystemic collaterals we talked about? Yeah, that's what we're talking about. Now, here's the thing. These fragile venous walls are just not meant for these high pressures. Like these high portal hypertension pressures that are just mashing on these poor little venous walls, that's not what they're meant to do. Veins, that's not their job. So what often happens, unsurprisingly, when you have these fragile veins exposed to high pressures that they're not built for, bleeding happens all the time. And GI bleeding all the time in these patients. Now, when they come in and they're like vomiting blood like a fountain, it's not that hard of a diagnosis to make. Unfortunately, they often don't do that. Often, it'll be occult bleeding. And I have gotten burnt so many times by being like, oh, it's not a GI bleed because they came in and I thought they were in renal failure or septic or altered. Now when I see one of these patients who's altered, maybe hepatic encephalopathy, I think occult bleed, if their BUN, if they're in renal failure, but specifically if their BUN is really high, because all that ammonia broken down protein, right? If their BUN's really high, I start thinking about it. And then lactate. Because remember, lactate does not equal sepsis. Lactate equals hypoperfusion of any stripe. And as we'll talk about later, the liver doesn't clear lactate well. So if I see a patient who's not like overtly bleeding at me, but I'm like, I don't quite know what's going on, something doesn't seem right, and I don't really have a source of infection, I will go chasing an occult GI bleed. The other important thing to understand about GI bleeding in cirrhotics is, interestingly enough, mortality is often due more to the complications of the bleeding rather than the bleeding itself. And this is important because when you're thinking about treating them, it's important to have in the back of your head that more often these patients aren't dying of hemorrhagic shock. They're dying of complications like renal failure, like sepsis, like aspiration. Now, how are we treating these patients? Upper GI bleed treatment? Well, we are going to give them the ceftriaxone 2 grams. Perfect, that's actually probably one of the more important things you give them. Then you're going to start your octreotide bolus and your octreotide drip. It turns out that a lot of these patients actually also have ulcers. In fact, a fairly high percentage of them also have ulcers. So I usually will give them a dose of pantoprazole. That's optional. And the drip is also optional if you don't know if they have a history of that, and especially if you don't have enough access, because the very first thing, step 0 on these guys, is get access. These guys often have really good EJs because, like, for the same reason they're bleeding, they have good EJs in a way, those distended veins. So often their arm veins suck, but they have really good EJs. So I'll often go there. And then, of course, you got to call GI and work on the upper endoscopy situation sooner rather than later. So that, in a nutshell, is the treatment of upper GI bleed in cirrhosis. Now, what gets more complicated is the blood product resuscitation issue. So how are we resuscitating blood products with cirrhotics? So these guys, this is where things get dicey because it's a Goldilocks kind of thing. This was an interesting paper looking at the variables associated with death in alcoholic cirrhotic patients with variceal bleeding. And interestingly, what they found were that the only 2 variables that were significant predictors of rebleeding were 1, their bili, sure, but 2, the number of blood products that got transfused. Now, obviously, the more bleeding you have, the more you get transfused, but even once you control for that, it's become pretty clear that overtransfusion in these patients causes significant problems. And a study came out several years ago that sort of confirmed that what we were thinking already, that in fact, overtransfusion in these patients can be a huge problem. And in fact, restrictive transfusion strategies, targeting hemoglobin of less than, 7-ish, in fact, were not just like equally okay, they were actually better. They actually did better with giving less blood. So what do you do with that? This is how I approach it. If I have a stable patient who I'm like, I think GI bleeding is your problem, either, you have a history of it, I think that's what's going on, it looks like that on the labs. If you're stable, I am going to target a hemoglobin of 7. I am not going to try and get it higher than that, I'm just going to target a hemoglobin of 7. If the patient's unstable, treat them like any other patient who's dying of bleeding. You transfuse them what you need to, the hemoglobin doesn't help you in that moment, and, you target perfusion, right? Now, if you're doing a massive transfusion of a massively bleeding cirrhotic patient, you now start to run into some other complications, which is the other reason these patients bleed. They're very coagulopathic. And unfortunately, they're not coagulopathic in a nice, simple, straightforward way. They're coagulopathic in a very annoying way because, one, their coagulopathy is bidirectional, and two, it's multifactorial. So one of the big issues with these patients is that they do have an increased tendency towards bleeding, but not to be left out, clotting also is like, yep, me too. They also have an increased tendency towards clotting. They like to clot and bleed at the same time. So it's not just the bleeding. Now, the causes of all of this is also multifactorial. The platelet number sucks, but also the platelet function sometimes isn't so good. Their clotting factor production, not so good. The liver's not doing its job. But they also have a lot more fibrinolysis, and their nutritional status often not awesome. And so because of this multifactorial process, or processes rather, their bleeding can be very hard to control, and their coagulopathy can be very hard to control. And it's often not as simple as giving them one unit and calling it a day. Okay, I have for you, however, my top 3 management pearls for coagulopathy in chronic liver disease. Okay, here we go. Ready? Pearl number 1, do not give FFP for INR. Pearl number 2, do not give FFP for INR. And pearl number 3, do not give FFP for INR. If I see one mistake over and over and over again that hurts patients, it's people just having this compulsion to try and get the INR less than 1.5 in a cirrhotic patient. They just can't help themselves or something. The INR in cirrhotics doesn't measure anything having to do with bleeding. I'll say it again. It has nothing to do with bleeding. It tells you a lot about their liver function. And if they're bleeding to death, it'll probably become abnormal in the same way as anybody else who's bleeding to death, but it doesn't tell you about their bleeding. This was a recent clinical practice update from the AGA. And again, because it's important, I'm going to read this quote for you guys. Laboratory measures of hemostasis have significant limitations in these patients. INR is the most problematic because of its entrenched but unfounded position in traditional medical teaching. And they just put it right out there. FFP is not recommended to correct any coagulation factor deficiency. Use of FFP to, quotes, correct a prolonged INR in cirrhosis does not actually change thrombin production, but does actually exacerbate partial hypertension. So it doesn't make it better. It may make it worse. It's pointless. But I'm not saying just like never ever give them FFP. I'm just saying that treat giving them FFP like you would any other patient, right? Their INR being high doesn't tell you they need more FFP. You're not going to fix it. You're going to overtransfuse them and make it worse. So you're going to treat them like any other patient when they're massively bleeding, following the rule of massive transfusion, which is put back in what comes out. That's the golden rule. If you have 1-to-1-to-1, because you're bleeding reds and platelets, and plasma, put all of those things back in your patient like you would for any patient. Now, on top of this base 1-to-1-to-1 strategy, I will often sprinkle some things on top, and I'm more likely to do this in liver patients. So I'm much more likely in liver patients to sprinkle some cryoprecipitate on top, and I'm also somewhat more likely to sprinkle some TXA on top. Now, cryo, these patients have all kinds of issues, and often their fibrinogen is quite low, and that number means something to me. So I'm more likely to probably give them cryo. It's complicated whether or not that's clearly always indicated, but especially if they're just bleeding and bleeding, I can't get them to stop, I'm more likely to start getting more aggressive. TXA, this is still, we don't really know yet. There's been a lot of debate about this, and there's a study that's currently being done, and so stay tuned because maybe we'll have an answer in terms of TXA in bleeding cirrhotics. We don't yet. Right now, I'm on the fence. Importantly, when you are massively transfusing these patients, don't forget your calcium. So you know how blood products are kept, liquidy and not clotty by calcium citrate, right? So citrate chelates calcium, right? When you give people a bunch of citrate in all of that blood, normally the citrate's cleared by the liver, which is great. Oh wait, except this patient has liver failure. So these patients get hypocalcemic much more rapidly and profoundly than patients without liver failure. So I'm very aggressive about repleting their calcium, because if you don't, they're just going to get hypotensive from straight up vasoplegia from hypocalcemia. So be very attentive to their calcium. Okay, item number next, infections in cirrhosis. Unfortunately, they are more frequent and more severe. Why? Well, because again, portal hypertension and systemic vasoplegia are to blame. So the deal with infectious susceptibility in chronic liver disease, it's significant, right? So portal hypertension. This causes bacterial translocation because you have these high pressures across the sort of GI system walls, and it just mashes bacteria out where you don't want it. So more translocation, you get more infection. More infection, and then you add infection plus this baseline systemic vasoplegia that they have, and you have a setup for a high risk for septic shock that can be quite profound in these patients. Now, the problem is infection can be beautifully camouflaged in these patients because they can be an everything failure. It can be very difficult to, again, shake an egg. What's my primary problem? What's my secondary problem? And they can look like the primary issue was a GI bleed, but oh wait, maybe their primary issue was actually sepsis. It can be very, very tricky. I have a very low index of suspicion of infection in these guys, and I have a very low threshold to initially antibiose them because I've just learned that I can't always tell what's happening. It's hard to figure out. And the thing about sepsis in cirrhotic patients, it's always almost the first domino. That if they get septic, it's usually the thing that like pushes everything else over the edge. Now, this whole process is made more difficult is because lactate is often high in these patients. The liver clears lactate. It's not doing their job in any context. So I'll sometimes hear people be like, well, the lactate's high, but maybe they're just not clearing it. I would say to that, yes, but no. The mortality rate for patients with elevated lactate, just looking at all comers, end-stage liver disease, elevated lactate is absurdly high. So if I see a patient who's cirrhotic, who has elevated lactate, I just assume serious badness is happening until proven otherwise, and just kitchen sink. This is the time to throw the kitchen sink at them, basically. And so again, this is not the moment to like, well, maybe the clear, just like something bad is happening till proven otherwise. A special infection that these guys get is, of course, SPP. Now, what's tricky is their exam can be very deceptive because all of that fluid in the peritoneum means that the exam may not be that impressive because the inflammation that's usually supposed to cause that peritonitic feeling, oh wait, there's this like literal fluid cushion in there. So sometimes the exam can be deceptively benign. Now, another important primary versus secondary moment, you can have both a primary, truly spontaneous SPP, but you can also have an infection of the peritoneum. You can have a, secondary SPP, really should be secondary BP, anyway, because you had some kind of other abdominal pathology, like a perfed viscus, for example, or any other normal abdominal problem somebody would have. It's just that it may not present as dramatically, and if you tap them, it'll look like an SBP, even though the real problem is that they, have a toxic megacolon. So the thing about primary versus secondary is that secondary is more rare, but if you miss it, then the mortality rate's almost 100%. So diagnosing this, I never remember this number. I have to look it up every time. But diagnosing an SBP, what you're going to do is you're going to get the fluid, and your diagnostic criteria is your absolute PMN and over greater than 250, and that is how you calculate it right there. Your total whites times your percent PMNs. That's how you calculate it. Now, if you get this, and the patient's just super sick, and you're like, is it possible they have a secondary SBP? Findings that would suggest that to you in the fluid include things like, is it polymicrobial? Is there a bunch of different gram negatives all over the place? Is the glucose low? Is the protein high? So if I see a patient where I get their studies back, and that's what I'm looking at. I'm looking at, this fluid that not only are my PMNs high, but it's polymicrobial, low glucose, high protein. I'll consider scanning that patient because I'm wondering, do I have a secondary SBP? So treatment, ceftriaxone is fine. I have had people recommend cefotaxime to me just because of penetration into the peritoneal cavity. It's generally what I use, but ceftriaxone is completely reasonable. Now, in addition, there's actually some reasonable data on giving albumin for this. So I will give them some albumin in the ED, and especially if they have renal failure, because renal failure developed in the context of SVP is badness. The mortality rate's very high. So if they have renal failure in the context of SVP, I just straight up add some norepi if I'm sending them to the ICU to support the blood pressure, support the renal perfusion, because basically the belly's trying to suck all the perfusion away from the kidneys, you're trying to get it back to the kidneys. Or if they're not going to the ICU, so I can't do levofed, then I'll do octreotide, drip, and or add on some midodrine. Okay, and next, renal failure. So, hepatorenal syndrome. This is yet another place where, the same pathophysiology happens. So, we start with systemic vasoplegia. This is causing a decrease in the effective arterial circulating volume, right? This happens sometimes. It can happen, in heart failure patients for different reasons, but in liver patients, it's this same thing, just a different mechanism, because their vessels just can't clamp down. They can't do their job. Now, when that happens, when they're so vasoplegic that the body's like, I don't have any pressure in my vascular system, guys, like, where's all the blood? Well, that makes the kidneys, who are not very smart, be like, oh, don't worry, I'll come to the rescue. And the kidneys go nuts. And what do? They activate the renin-angiotensin-aldosterone syndrome. It just gets upregulated like crazy. Now, the problem with this is that, what does it do? It causes pretty intense renal vasoconstriction. And it doesn't actually fix your problem because, that's not really the problem in the first place. The problem is the liver disease and the sort of like systemic vasoplegia. The kidneys don't know that, but they've done nothing to fix the problem. All they've done is now we have intense renal vasoconstriction. And that intense renal vasoconstriction, when coupled with the still present systemic vasoplegia, easily results in renal hypoperfusion. Now, your job is to figure out, do I think that my patient has an acute kidney injury secondary to something else wrong with them, or do I think that this is true hepatorenal? And this is a really important distinction to make. And you're crossing your fingers for the first one, because hepatorenal syndrome has an abysmal prognosis, and really the only fix is a liver transplant. So acute kidney injury. So it happens all the time. Sepsis, SBP, GI bleed happen all the time. And if you get a patient who has sepsis, GI bleed, or SBP, and they also have acute kidney injury, it's associated with a way higher mortality rate if they develop it. So take those patients very seriously. If you think that this is acute kidney injury in the context of something secondary, just fix the underlying cause like you normally would. Fix the sepsis, fix the bleeding, fix the whatever it is. But if you are unsure, and you're like, it could be AKI in response to one of these things, or it could be hepatorenal. If you don't know, I just will empirically treat them for hepatorenal because hepatorenal has such a high mortality and because it's a diagnosis of exclusion. To make the diagnosis of hepatorenal, you have to be like, okay, I checked and, they don't have any other reason for their renal failure, so it must be hepatorenal. It's going to take a minute to figure that out. And part of that is figuring out, does the creatinine get better when you fix the other thing? So I often just throw the kitchen sink at these guys and just treat them. So if I'm going to treat them for hepatorenal, then your treatment is geared towards what you're trying to do here is you're trying to steal blood from the splanchnic circulation and send it to the kidneys. How are we going to do that? Well, we're going to do some albumin. There actually is some decent evidence for albumin here. And we are going to try and actually correct that vasoplegia. So if we're sending them to the ICU, we're going to do some norepi. But if you're not sending them to the ICU, that's okay. You can do octreotide, which you can do on the floor, and then some midodrine. So again, get the fluid in the vasculature and then send it over to the kidneys. Don't let the spleen steal it. Okay, item number next, pulmonary. So these guys come in with two basic pulmonary problems. Well, many, but the two key ones. One, hepatic hydrothorax. This happens not infrequently. It's the more straightforward one, so that's why we're starting with it. Now, this usually happens on the right, as you might imagine, but don't be deceived because it can also happen on the left. I had one patient when I was a fellow who only got it on the left, and it was very confusing for everybody because we're simple humans, but the liver's on the right. Anyway, it can happen on either side. Only do a thoracentesis here based on symptoms. The thing with these patients is that frequent, recurrent, excessive thoracenteses seem to actually make things worse. Not to mention the fact that they can develop a spontaneous bacterial empyema, which, as you can imagine, is not good, even a little bit. So, I really just do it based on symptoms. I don't do it based on chest x-ray. If their chest x-ray looks not good, but they're looking fine, and if they're lying flat okay, and they're breathing okay, and they're not symptomatic, so just tap it based on symptoms and clinical status, not based on imaging. Because not only do you run the risk of infecting it, but, chest tubes in these patients can be dicey. Because if you put one in, interestingly, the mortality of those patients who get them left in for hepatic hydrothorax is quite high. So I usually won't leave one in. The exception to that is both the draining and the leaving it in is if I do think that this might be an empyema. Like if the patient's super septic, I can't find a source, and I'm like, Okay, could that hepatic hydrothorax be infected? That is sometimes when I'll tap it for a reason other than symptoms. Okay, now let's talk about hepatopulmonary syndrome, which is a super interesting and initially mind-bending thing for me that I'm now going to tell you about. It's probably more common than we think. So this is a syndrome that you see with end-stage liver disease, and we probably under-recognize it, but I bet when I tell you about it, you may have a moment when you're like, oh, that one patient, I get it now. So again, we're dealing with the consequences of systemic vasoplegia. Now, asterisk, keep in mind, that includes your pulmonary vasculature. So what happens is, just like your systemic vasculature, your pulmonary vasculature can't clamp down. And so what that means is that you get this failure of ventilation perfusion matching. Because vasoplegic pulmonary vasculature, you get failure of hypoxic pulmonary vasoconstriction, right? So that's where basically your lungs are like, I want to send the blood from the areas of no oxygen to better oxygen. How do they do that? Well, the pulmonary capillaries, when they see hypoxemia, they contract, they constrict, sending the blood to the areas of better oxygen. Unless, of course, they're vasoplegic and they can't do that. So you get this VQ matching failure, and then you get hypoxemia because of it. Now, what you end up seeing is the profound dilatation of pulmonary capillaries. That's what's caught, right? Like they're vasoplegic, the pulmonary capillaries can't clamp down, but, eventually they just get so big and dilated, they're just ginormous. And they're the biggest at the lung bases, right? That's where most of the blood sits most of the time. That's when they're the most dilated. So there's some implications of that. And they go as follows. Normally, on a normal day in a non-liver failure patient, oxygen diffuses great. Oxygen diffuses all the way through the entire pulmonary capillary, no problem. That's not usually an issue. But what about if you have this big, massive, fat pulmonary capillary? Because they can be like 30 times the size of normal pulmonary capillaries. Watch what happens. Sometimes it's so massive that oxygen is unable to fully diffuse through the entire thing. So now look at what the implications of this are, right? This profound dilation of the pulmonary capillaries is worst at the lung bases, okay? Now, what are the implications of that? Well, that's where this gets interesting, because the implications of that are, if this is worst at the lung bases, you would expect things to get worse when more blood is sent to the regions where you have the biggest problem, right? So normally, most of the blood, just because of gravity, is in the lung bases when a patient is sitting up. So we just have predicted that maybe actually their hypoxemia will get worse when they're sitting up. That's exactly what happens. And this is why. This is pathognomonic almost for hepatopulmonary syndrome, where it's this bizarre thing where you used to seeing a patient who's short of breath. So what do? You sit them up. Because we all know, like, laying a patient down with shortness of breath, that never helps anything. So you sit them up. But it turns out these patients actually get worse when you sit them up because you're sending the blood to the worst parts of the lungs. And there's a name for this. It's called platypnea and orthodeoxia, basically, and it means that they breathe better lying down. And it just like gets super confusing. And like, there was just this patient, and this is when I read about this, when I was like, I don't understand, this doesn't make any sense. But you can see that. Now, what is the treatment for that? Unfortunately, there's not a great treatment for it other than to sort of like recognize what this is, to know what this is, and to just realize that it gets really bad, but mostly just to like stop laying your patient down every 5 minutes, and that's why they can't breathe. Okay, very briefly now, metabolic. Let's talk about the pathophysiology of now hyponatremia, because again, systemic vasoplegia is at fault here. We have the same problem. The kidneys are like, we have a decrease in effective arterial circulating volume. That's bad. What should we do? I know, we should activate, again, the renin-angiotensin-aldosterone syndrome. And that doesn't fix the problem, but the kidneys just aren't getting it, and so that is how you end up with hyponatremia. Now, the thing to know about hyponatremia in these patients is that they're often hyponatremic. It is a globally bad prognostic sign, but it's rarely the cause for their acute altered mental status. And so it would be a mistake to be like, the patient's sodium is 125, that's why they're altered, because it's usually not. They usually chronically live there. And so I'm pretty thoughtful about trying to correct their sodium, because often it's not the culprit. If you can get a baseline sodium so you know what it is, that's very helpful. But certainly don't attribute their altered mental status to hyponatremia unless you have really fully worked them up for other stuff. So these are all of the possible disasters that you can get, or not even all of them. These are some of the most important possible disasters that you can get with the cirrhotic patients in the ED. in a big picture global way, when you're trying to figure out how to take care of these patients, it is useful to know their transplant status. But, I'll say even so, even in ones who aren't eligible for transplant, you can still make a big difference. To review, as I was saying, high risk but rescuable. And in the patients who aren't transplant candidates, sometimes they just don't make it, but you can often make a big difference in how they look. And they look fantastic coming out, or at least maybe not fantastic, but they look better than they did going in. A big thing to keep in mind with these patients is really focus on, do I have a primary problem or a secondary problem? Has my secondary problem now become more difficult to deal with and problematic than my primary problem is? That happens all the time. To know that a lot of the pathophysiology underlying this is either through portal hypertension or systemic vasoplegia. And then to keep in mind that this is a multi-organ system condition, that all organ systems can be down, and that is often why these patients are so very, very sick.